Hello, everyone, and welcome to the World Ophthalmology Congress. I am Amgad Eldeep. I work at the UPMC Children's Hospital of Pittsburgh, and together with my co-chair, Dr. Cristiane Rolim from the Federal University of Sao Paulo, Brazil, we would like to welcome you to our session, Managing the Pediatric Glaucoma Suspect, where Dr. Arif Khan will walk us through the genetic predispositions you should not miss. Dr. Arif Khan is from the United Arab Emirates. That is followed by Dr. Preeti Patel from USA, talking about the masquerading optic disc. Then Dr. Vinay Gupta from India will talk to us about how the optic disc has the answers. Then I will walk you through some of the testing modalities I have found very useful in the pediatric glaucoma suspect. Dr. Xuelan Zhang from the People's Republic of China will then talk to us about when to consider angle surgery in older children. Finally, Dr. Yoshiaki Kiyuchi from Japan will walk us through which drops to use in case we feel the need to start treatment. Once again, I would like to thank you for joining our very interesting session and somewhat challenging topic, and I hope you enjoy it. Thank you.
Greetings, everyone. My name is Arif Khan. I'm at Cleveland Clinic, Abu Dhabi, and it's my pleasure to participate in WOC 2022. I've been asked to speak about genetic predispositions you should not miss in reference to pediatric glaucoma. I don't have any relevant financial disclosures. So family history is an important predisposition. Here's a baby with congenital glaucoma, and it was obvious at birth. And when other children are born with obvious congenital glaucoma, it's obvious. And when a child is born without obvious congenital glaucoma, the family might be more relaxed. What I want to highlight to you is that in family members of children with congenital glaucoma, there is a risk for glaucoma even if there is not obvious congenital glaucoma at birth. Because of variable expressivity for congenital glaucoma, siblings and even parents of patients of children with congenital glaucoma are at risk for glaucoma, even if they didn't have glaucoma at birth. In this particular family, the sibling of this child had obvious congenital glaucoma. This child had obvious congenital glaucoma, but the father actually developed a juvenile glaucoma. And when we did genetic testing and identified the genetic cause in this family and looked at other family members, we identified some other individuals who had two mutations. That is to say, they had the genetic disease. They didn't realize they had glaucoma, but they had subtle glaucoma. So individuals with congenital glaucoma, just because a sibling or family member doesn't also have congenital glaucoma, that doesn't mean that they're out of the woods. There is a risk for glaucoma in relatives of patients with congenital glaucoma because of variable expressivity for the disease. Here's another family. You see this individual highlighted with the yellow arrow. That individual had obvious congenital glaucoma. But all of these individuals with the red arrows, they had the same genotype, and when examined were found to also have glaucoma. They didn't even know it. They were thought to be okay because they didn't have the obvious congenital glaucoma of the proband, but in fact, because of variable expressivity, they developed glaucoma later on. Cascade testing, that is to say, testing family members of a proband once the genetic cause is known, can be helpful in identifying individuals who are at risk for glaucoma. Cascade testing has also been shown to be very useful for juvenile glaucoma from mycelium mutation. These individuals can have glaucoma and not even realize it until they have very advanced disease. So that family history is an important genetic predisposition you should not miss. The next concept I'd like to share with you is that of non-acquired ocular abnormality. And here I'm using the terminology of the Childhood Glaucoma Research Network. This is a terminology we should all be familiar with. In classifying pediatric glaucoma, when we have non-acquired ocular abnormalities, certain forms, there is a risk for glaucoma. So here's a child who's born with no iris, no visible iris, lens opacity, peripheral keratopathy, foveal hypoplasia. This child has classic aniridia. And although the child doesn't have glaucoma at this time, there is definitely a predisposition to glaucoma, and the child needs to be followed for this possibility. children with anterior segment dysgenesis, even if they don't have glaucoma at the time of examination, need to be followed lifelong for the potential development of glaucoma. Here's a sad case, a 3-year-old boy whose parents were told that nothing was of concern when they brought the child in because of abnormal eye appearance. Basically, this child had an appearance of what is known as congenital ectropion uvei, that is to say, this iris discoloration, and didn't have glaucoma at the time of examination, but were told not to worry about anything. Unfortunately, a year later, the child came in with frank glaucoma in that eye, and actually there was a lawsuit brought against the initial ophthalmologist because that ophthalmologist had said there was nothing of concern. Whenever you have an anterior segment dysgenesis, we have a predisposition for glaucoma. We need to follow these patients as glaucoma suspects for life. The third genetic predisposition I'd like to share with you, again using terminology from the Childhood Glaucoma Research Network, is non-acquired systemic disease or syndrome. There are certain non-acquired systemic diseases and syndromes that are genetic predispositions for pediatric glaucoma. Here's a boy with developmental delay. He's got arched eyebrows. He's got microcephaly. He has low-set dysplastic ears. And also, interestingly, he has these stubby fingers and toes. He has the phenotype of Rubinstein-Taybi syndrome. And indeed, genetic testing confirms he has this. And he has some systemic risks, but another risk he has is a risk for glaucoma. There are certain syndromes that can confer a risk for glaucoma, and these patients need to be followed regularly, even if they don't have glaucoma at the time of initial assessment. Here's another child, that is, this child has hearing loss, and you can see that the eyes are widely spaced. The forehead is slightly prominent. There is a thin upper lip. And although the eyes are covered there, this is what the eyes look like. She's got a very prominent posterior embryotoxin. This girl has Axenfeld-Rieger syndrome, and although she doesn't have glaucoma, she's at very high risk for glaucoma and needs to be followed for that possibility. It's a genetic predisposition we should not miss. So to summarize, I've gone through, in the time allocated to me, some genetic predispositions you should not miss. Family history, I want to highlight that family members of babies with congenital glaucoma can be at risk for glaucoma that is not congenital onset. We have responsibility to these family members. Genetic testing and counseling can be very useful in these situations. Patients with non-acquired ocular abnormality and non-acquired systemic disease or syndrome that predisposes to glaucoma needs to be followed lifelong, even if at the time of initial assessment, glaucoma is not present. Thank you very much, and enjoy the rest of the meeting.
Hello everyone. Today I will be talking to you about the masquerading optic disc, or when is optic nerve cupping not really glaucoma. At the outset, I have no financial disclosures. Let's start this discussion with a case. So we'll start with our first case, which is that of a 17-year-old male who was seen for the suspicion of glaucoma. He really doesn't have much of a past ocular history. He has mild hyperopia of about half a diopter each eye. His visual acuity is 20/20 in each eye, and his intraocular pressure with the Goldman applanation tonometry is 15 and 14 in the right and left eye respectively. These are his optic nerves. So you can see here the rest of the fundus looks pretty good, and let's take a closer look at the nerves. The nerves here have a slightly large cup, so you would definitely say this is a larger cup. It's a cupped nerve with about a 0.6 or so cup disc ratio. There are some peripapillary pigment changes as well. I'm going on now to their visual field. So this is the visual field, which was largely within normal limits in both eyes. This is the OCT of the retinal nerve fiber layer, which shows that the retinal nerve fiber layer was within normal limits in both eyes, 93 and 99 in the right and left eye respectively. At this point, we had a few more questions about history. Was there any family history of glaucoma? There wasn't. And was he born prematurely? Yes, he was. He was a former 26-weeker with history of developmental delay. So what is the relationship between large discs and prematurity? The newborn brain is susceptible to various external influences. The most common of these damaging influences is the lack of oxygen, that's hypoxia, anoxia, low blood sugars or hypoglycemia, or most commonly a combination of both. The areas of damage in this newborn brain are related to the gestational age at which this event occurs. In full-term babies, the striate and the peristriate cortex are more likely to be involved, whereas in preterm babies, it's the subcortical white matter, which includes the optic radiations. Early prenatal damage may result in really small optic nerves, like optic nerve hypoplasia, whereas lesions that occur after 28 weeks of gestation may result in normal-sized discs with large cups as a result of the reduction in the number of axons. And this is what often causes the pseudoglaucomatous cupping that we are seeing. Transsynaptic degeneration occurring after damage to the retrogeniculate pathways in this perinatal period is often responsible for this pseudoglaucomatous cupping. So it's really important to ask for a history, a good history asking for prematurity, history of prolonged stay in the NICU, and developmental delay. It's a good idea to review the neuroimaging, and serial monitoring of the optic nerve head with serial photographs, visual fields, and OCTs over time will be important to make sure that this is staying stable, that the optic nerve appearance is stable. It's also important to remember here, depending on what the neuroimaging shows and where the damage has been to the visual pathways, the visual field deficits may often be out of proportion to the optic nerve changes. This is another child with a similar history. You can see here the optic nerves have large cups. You can also see this MRI, which shows asymmetric enlargement of the ventricles with loss of the periventricular matter. This is often an indicator of volume loss. So it's important to remember that optic nerve cupping is not always glaucoma. Coming to our second case, this is a 10-year-old girl with history of blurred vision, visual acuity 20/20 in each eye, good color vision, and minimal refractive error. These are her optic nerves. You can see again, looking at the optic nerve cups, certainly the cups are larger than what you would expect for her age, so at least about a 0.6, 0.7 cup. But when you look more closely at the rim that's left behind, let's blow that up a little bit. And here you can see that the rim is not of a normal color. Compare the color of the temporal rim to the nasal rim, and you can see that the temporal rim is definitely pale. So although this nerve is cupped, the rim that's left behind is also pale. The OCT shows reduced retinal nerve fiber layer in this case, with 78 in the right eye and 77 in the left. And here, when we delved a little deeper into the family history, we found out that the mother also has history of poor vision and optic atrophy that was diagnosed at the age of 4. This child underwent genetic testing, which showed some variants in the gene that have been associated with autosomal dominant optic atrophy type 5 or OPA type 5. So it's important to remember that optic nerve cupping can also occur in non-glaucomatous conditions like optic atrophy. It has been described in dominant optic atrophy, in Leber's hereditary optic neuropathy, and in toxic and nutritional optic atrophies. It's really important, therefore, to look for the color of the rim. When you're looking at the cup, look at the rim next to it and what the color looks like, the pattern of the visual field loss. Glaucoma usually spares central vision, whereas non-glaucomatous optic atrophy more commonly has central or secocentral vision loss. Color vision is usually preserved in glaucoma, And the pattern of the RNFL loss on the OCT, the retinal nerve fiber loss on the OCT, can also point you in the right direction. Hereditary and nutritional optic atrophy tends to involve the papillomacular bundle the earliest, so you would see the temporal nerve fiber layer thinning out first, whereas the loss in glaucoma is more diffuse. Let's come to our next case. This is a 6-year-old boy who was referred to us after a routine check. His vision was 20/30 in both eyes for distance and 20/20 at near, with color vision in both eyes. This is his left optic nerve. So when you first look at this nerve, you do look at the cup and you think, well, that is a slightly deeper and larger looking cup. Let's look at his right nerve now. His right nerve, you can see, doesn't really have much of a cup. In addition, there's also this central tuft, almost like of a glial tuft. And now let's look at the blood vessels. The blood vessels you can see here don't have that typical branching pattern, but seem to come out more from the rims rather than from the central branching that you're more accustomed to seeing. So we have to remember that congenital optic nerve anomalies can also mimic glaucoma. Optic nerve colobomas, morning glory disc anomaly can look like a glaucomatous cup sometimes. So it's really important to look for anomalous vascular patterns, vessels that may be displaced by the coloboma and emanate radially from the margins, a central glial tuft of tissue which points towards the morning glory disc, peripapillary pigmentary changes, and segmental hypoplasia of the optic nerve can also be mistaken for glaucoma sometimes. So to sum it up, optic nerve cupping can be seen also in compressive optic neuropathy, and here it's really important to look for subtle patterns on the visual field like bitemporal patterns or homonymous pattern, pallor of the rim, and color loss of color vision. In adults, cupping may also be seen after ischemic optic neuropathy. So just to conclude, non-glaucomatous optic nerve cupping definitely exists and should be kept at the back of our minds whenever you're evaluating a glaucoma suspect. It's really important to get a good history, look at the vision, the color vision, look at the optic nerve rim and its color, the pattern of the vessels, the pattern of the RNFL loss on OCT, the visual field loss, and of course the intraocular pressure. Thank you very much for your patient listening.
So at the outset, I'd like to thank the World Ophthalmology Congress for inviting me to talk on this session about pediatric glaucoma suspect, and I'll be talking about how the optic disc has the answers. So the International Classification of Childhood Glaucoma has conclusively shown that progressive increase in the cup disc ratio, asymmetry of the cup disc ratio between the two eyes, especially if the disc is of similar size between the two eyes, and thinning of the neuroretinal rim are important criteria for labeling a child as glaucomatous. So if you have a child who has large corneal diameters, harp striae, increase in intraocular pressure, the diagnosis is pretty much clear. However, there are cases where the optic disc might be suspicious, and these children are referred to a glaucoma specialist to conclusively say whether this is glaucomatous or not. In these cases, evaluation either under sedation or under anesthesia is a question, and I personally would prefer to examine under anesthesia to actually evaluate the optic disc properly, and if possible, take photographs of the optic discs. Here you can see the optic discs of a child where there is an obvious increase in the cup disc ratio, thinning of the neuroretinal rim, and it is obviously glaucomatous. On the other hand, there could be optic discs like this where it is a large cup disc ratio, but you can also see that the neuroretinal rim is healthy and is following the isn't rule. So in this case, it is a physiological large cup which is present in a large optic disc. This is a more extreme situation where there is an asymmetry between the optic disc size between the two eyes, and therefore it leads to a very large cup. But carefully look at the neuroretinal rim, and you can see that the neuroretinal rim is healthy, and hence this is unlikely to be glaucomatous. There could be other anomalous discs that are referred to us because the disc is vertically elongated and giving a wrong impression of a large cup when actually there is a disc anomaly here. In this case, again, you can see that there is a discrepancy between the two eyes, but here look carefully at the neuroretinal rim, which is thinned out. There's nasalization of the vessels, And despite the fact that the disc is large, even the cup disc ratio is large with a thin neuroretinal rim. So there's a very strong suspicion that this child has glaucoma and therefore has to be followed up very carefully. So if you look for the thinning of the RNFL in the form of RNFL defects, you can see these in children. Again, they become a very hard sign to say that yes, this is glaucomatous. So thinning of the neuroretinal rim or the presence of these RNFL defects give a clue to the possibility of glaucoma. I haven't seen retinal hemorrhages in children, but in adults, if retinal hemorrhage is present in the form of a splinter hemorrhage at the disc margin, that again is a very strong indicator of it being glaucomatous. Then there could be discs which are tilted, discs present in high myopes and extremely shallow cups in high myopes. In fact, all high myopes should be considered to be glaucomatous unless proved otherwise, because in these eyes, it is very difficult to ascertain whether it is glaucoma or not. We have also seen patients where the glaucoma had progressed, and here, apart from progression of the optic disc cupping, there was change in the disc morphology, and there was also a progression of myopia. Similarly, from Seoul, South Korea, there has been a study in children which showed that with progression of myopia, there were some children that were also developing glaucomatous changes in the optic disc. So there was a change in the disc morphology, as you can see, with progression of the myopia, but there is also a progression towards glaucoma, despite the fact that all of these children had normal intraocular pressures. So therefore, if you see that in a child, the myopia is progressing, and you see that the disc morphology is changing, carefully look at the neuroretinal rim, because this child could be going into a glaucoma despite the fact that his intraocular pressures are normal. This again emphasizes the fact that we need to take disc photographs in children. We need to evaluate the children with a proper disc evaluation done with fundus photography, and we have handheld fundus cameras. Even if you cannot get very good, clear fundus photographs as you would get in adults, even a hazy view of the fundus which shows cupping and which is indicative of the eye being glaucomatous. Again, you can see that in this child there is a cupping of the optic disc, extremely thin neuroretinal rim, nasalization of the vessels. Even if it's a hazy view, it gives you an indication that yes, you're dealing with glaucoma. This is a child with retinopathy of prematurity, and here you can see that there is a thinning of the neuroretinal rim, there is cupping and these are a lot of such children are being sent primarily because there is a suspicion of glaucoma, and in ROP it is you invariably get very large cups which could be physiological, but at the same time you have to keep an eye on the intraocular pressure as they could be glaucomatous also. This is another child of ROP, and here you can see that there is regression of the cupping. So you can see that as the intraocular pressure gets controlled, there is a miraculous change in the cup disc ratio, which almost comes to normal. Then there could be children who have got very thick corneas, hazy corneas, which give a falsely high intraocular pressure readings. And there is no way by which you can ascertain whether it is glaucomatous or not, because you cannot see the fundus, in which case ultrasound really helps in showing an excavation of the disc and ascertaining the fact that this eye is glaucomatous. So to summarize, in pediatric glaucomas, looking at the asymmetry of the disc cupping is important, but also one must compare the optic disc size, because a large optic disc can give rise to a very large cup. Always look at the neuroretinal rim in these cases to ascertain it is glaucoma or not. Similarly, congenital anomalies of the optic nerve head must be understood and must be observed carefully and looked for before one labels that particular optic nerve as being glaucomatous. And if all other parameters in a child are normal, it's best to take optic disc photographs and look for change over a period of time, which can help in further decision making. Thank you.
Hello, everyone, and thank you for the kind invitation. I'm Amgad Eldeeb. I am one of the pediatric ophthalmologists at the UPMC Children's Hospital of Pittsburgh, and I will be talking about testing in the pediatric glaucoma suspect and what is useful to obtain. I have no financial disclosures, and we are talking about the glaucoma suspect, the child that you are seeing and you're suspecting something in his or her exam that raises the suspicion for glaucoma, but not a definite diagnosis of glaucoma. You don't have these classical signs and symptoms there. Now, you probably want to supplement your suspicion with some testing. And what is very well established in the adult population is a visual field test. But this is not unusual to obtain in a child with low reliability. And you get these high fixation losses, but you get these non-specific changes, which we all see here at the bottom of the screen. At that point, you're still not sure what you want to do with this child. And this is the Humphrey visual field map here. Now, if you are more familiar with the octopus, which is what I use more routinely at my practice, this is another example for another patient where you have lower reliability for the left eye, higher reliability for the right eye, but the right eye actually at the bottom of the screen has these changes that are more suspicious for an early nasal step. So that raises your suspicion for glaucoma. You repeat the same visual field for the same patient, not too long after that. Now you get less reliability, higher false positives for that right eye, but now you don't have that early nasal step. So you are not sure at this point which eye or which test you should go with and which one was the more accurate. Visual fields need you to select your patient quite well, and they need a great deal of reliability and cooperation from the child and may not be as repeatable as other modalities. Now, visual fields done on virtual reality testing seem to be a promising thing and may be more interesting for children, but still we need to see how that evolves over the next few years and hopefully in the near future. Structural loss may precede functional loss, so you may use the OCT as a modality to detect early changes, which may be more reproducible and more reliable in children. Now, I have an example here for this child with a very large cup-to-disc ratio, which you just happen to notice at the very end of your exam. Very large cup-to-disc ratio. You obtain an OCT and you have a healthy RNFL thickness map and a healthy GCL thickness map. But if you look at a very useful piece of information here, the disc area, this is a very large disc area and qualifies for it to be considered a megalopapilla, which may explain the large cup-to-disc ratio. Another example with the same patient. So if you zoom out here, you see that you can only fit one full disc between the edge of the disc margin and the fovea, which is one of the visual clues that you may use to decide on this being a very large disc diameter, which may explain the large cup-to-disc ratio, given that everything else is stable. This is another example for another patient with asymmetric cupping. On the right eye, you have less cupping. On the left eye, you have more cupping, and you may argue that this is 0.2 or more. Now, you get an OCT, which also shows on the disc area row here that you have asymmetric disc areas, which may explain the asymmetric cup-to-disc ratio. So this adds a very valuable piece of information. This patient also had healthy RNFL and healthy GCL maps. So there are multiple OCT devices, multiple modalities. You have older technology, newer technology, but there are no normative data for the pediatric population. You have to understand the device you have, familiarize yourself with it, and know what you are looking for. I am more familiar and comfortable with the Cirrus OCT, which compares patients to those of the normative data obtained in patients 18 years of age and older. No normative data for children. There are no normative data even for adults for the disc area, and that row you will always notice is grayed out on that scale or on that final table. If the disc area is below 1.3 millimeters squared or above 2.5 millimeters squared, the remaining rows in that same table are also grayed out, and you need to use your clinical sense to supplement the figures that you are obtaining with the OCT. What are you looking for when you look at an OCT printout? You want to look for good signal strength at the top. You want to look for good centration, good segmentation of the retinal layers. You then want to look at the sectoral maps and make sure that you have a good RNFL thickness map. And then also on the ganglion cell layer analysis, you want to look for good centration, good segmentation, and then you want to look at the individual figures and tables and try not to pay too much attention to the color coding green, yellow, and the red, because they have very sharp cutoffs and you want to look at the actual figures rather than the color. The guided progression analysis is a very useful tool to prove stability over time or detect progression. The ganglion cell layer and the RNFL layer maps are very useful. You want to look for these errors here. You have some movement artifact here, and in this here at the bottom, you have some segmentation errors. These may compromise the quality of your scan, so look out for those. And you want to make note that this is an unreliable test in case you do get one of those and not base your decision on this test here. Macular thickness maps are also very useful because if you have significant or ganglion cell loss that is affecting the macular thickness, then this is a significant change. And it may add a valuable piece of information and may help you or guide you towards your decision. Now, these two slides here are courtesy of Dr. Al-Kiliasis, who is the head of the electrophysiology units we have here at the Children's Hospital and at UPMC Ophthalmology Department. And there is recent literature to support that pattern ERGs and photopic negative responses may detect loss, given that you have a good baseline, may detect loss up to 1 to 2 years earlier than significant loss detected on a traditional perimeter. Now, most of this data was done in the adult population. There have not been much literature or very little literature in the pediatric population, and recent literature suggests that these may be useful for early detection, but not as useful for progression. So you have to keep those in mind if you are looking at possibly using electrophysiology in glaucoma suspects. At UPMC Children's, we are fond of these consensus-led evidence-based guidelines, and we had to come up with a protocol to help guide those more experienced and those less comfortable managing the pediatric glaucoma suspects to get them initiated and to see what is needed for them. This is my last slide, and it's a very busy slide, but I will try to walk you through it. So you may have a few things on your exam or the history that raise your suspicion. For example, you have a large cup-to-disc ratio or some peripapillary atrophy that's suspicious. You have a strong family history of glaucoma, intraocular pressures that you're not very comfortable with. Please pay attention to the pachymetry as you see up here, or you have significant myopic progression. Now, some of these may raise your suspicion for glaucoma and prompt you to get some testing. As a baseline, we recommend getting a fundus photo and OCT with ganglion cell analysis for that patient. Now, for the fundus photo, you want to repeat it once yearly. For the OCT with the ganglion cell analysis, you want to repeat it every 6 months, unless you think you can get a reliable visual field and you want to alternate between that and the OCT every 6 months. Gonioscopy is very important. You want to get that as soon as the patient allows you to do so. Cycloplegic refraction, we do that routinely every 6 months, and axial lengths when possible. We do get that routinely. There may be a few things that you find on the OCT. If there's progression, if there's thinning, you want to refer to the glaucoma specialist. If there is anomalies on the gonioscopy, myopic progression, or visual field changes, also refer to the glaucoma specialists. Thank you very much for your attention, and I would like to thank Dr. Ken Nischel for his continuous support and mentoring. Thank you.
Thank you, Professor Wei Zhang, inviting me here. My name is Shulan Zhang, came from Zhongshan Ophthalmic Center, Guangzhou, China. I would like to share with you when would you consider angle surgery in older children. I will present 5 minutes talk and then 3 minutes video. I don't have financial disclosure. Childhood glaucoma can be classified primary and secondary childhood glaucoma. Primary childhood glaucoma includes PCG, usually onset from 0 to 4 years old, and GOAG typically presenting after 4 years and up to 35 years old. And what is called older children glaucoma? I think you should include 3 parts. Children grown up from PCG, GOAG with normal angle, and GOAG with immature angle appearance. Dr. Gupta presenting in WGA webinar say there are 2/3 GOAG with immature angle, and literature also indicated that immature angle appearance is indeed exists in GOAG. Surgery in childhood glaucoma is more challenging than adult, including angle surgery, goniotomy, or trabeculotomy. And trabeculectomy or combined surgery, CTT, that is trabeculotomy plus trabeculectomy. Glaucoma genic devices, GDD, and cytophotocoagulation, and others. Filtering surgery, no matter trabeculectomy or CTT or GDD, with higher failure even with anti-scarring agent. And difficult to care post-surgical outcome in children. A lot of massage should be done after surgery. Angle surgery has become the first option for PCG ab external, ab internal. For example, 120-degree, 240-degree, and 360-degree goniotomy. Surgery for JOAG is still controversial. The current WGA consensus shows that medical therapy for JOAG is the first-line treatment. However, it is typically insufficient. Tube shunt surgery as well as GADD, that is 360-degree goniotomy, has been shown to be successful in JOAG. However, evidence remains weak for the optimal first-line surgical intervention for JOAG. Goniotomy has different range, but which one is better remains investigation. Literature shows that 90-degree, 120-degree, 180-degree, 240-degree, or even 360-degree, there are no significant difference. On the other hand, in clinical practice, many of the cases with PCG or JOAG following failure of filtering surgery has been successfully controlled by different range of goniotomy. This is also indicated that goniotomy should be the first choice. I will show you 4 videos after my talk. So let me summary. Childhood glaucoma surgery is more challenging than adult, and MIGS bring new options for the treatment of glaucoma. Angle surgery is the first option for primary congenital glaucoma. For 120-degree, 240-degree, and 360-degree goniotomy, which one is better remains investigation. For older children, goniotomy should still be the first choice, then filtering surgery. However, the presentation does represent personal opinion.
It's a great honor to have an opportunity to talk about my experience in this field. The title of my talk is Which Drops to Use in Cases That You Feel Need Treatment. Childhood glaucoma is a condition that develops in childhood. Childhood glaucoma is divided into two categories: primary childhood glaucoma and secondary childhood glaucoma. Both of them also are divided into several groups. The pathogenesis of glaucoma is owing to abnormal development of the iridocorneal angle, which can be resolved surgically in many cases. Surgery is the first choice of treatment for childhood glaucoma, and angle surgery is a procedure of choice for primary congenital glaucoma. Then what is the role of medical treatment? The consensus book mentioned that drug therapy is used as an adjunct in pre-operative period or after surgical treatment. Several reasons are raised. It is difficult to confirm the efficacy and effectiveness of drug therapy in infants. The systemic pharmacokinetics of drug therapy for glaucoma differs between children and adults. Patients themselves are uncooperative. This slide shows the medicine used in glaucoma treatment. IOP lowering effect of PGs is strongest and followed by beta blocker, CAI, and alpha-2 stimulators. In children, IOP lowering effect is a little bit smaller than that in adults. This table shows the local side effect of anti-glaucoma eye drops. Beta blocker is the most acceptable from this point of view. PGs and topical CAI have most acceptable systemic side effects. On the other hand, we must pay careful attention to the side effect caused by beta blockers and alpha-2 stimulators. We conducted a retrospective chart study to examine the drug use situation in our clinic for childhood glaucoma. 34 subjects, 58 eyes, were included in our study. Kaplan-Meier analysis shows a good success rate of single 120-degree trabeculotomy, which is very similar to others' reports. Although the gonio surgery is effective for primary childhood glaucoma, 24 eyes, that is 44.1% of subjects, were under medical therapy at their final visit. There are 13 eyes in one eye drop group. All of them are using PG's analog. Omidenipac isopropyl is a PG's analog, which we can use in Japan. It has similar IOP lowering effect to PGF2 alpha analog with less local side effect. In two eye drop group, the two eyes are using dorzolamide and timolol fixed combination eye drop. One eye is using fixed combination eye drop of latanoprost and cartiolol. PG-beta fixed combination eye drop plus CAI is popular for multiple eye drop users. Although the gonio surgery is effective for primary childhood glaucoma, 44.1% of subjects are under medical therapies. Considering the efficacy, safety, and one-dose convenience, PGs can be the first choice in our institute. PG plus beta blocker or CAI plus beta blocker fixed combination therapy are the second choice, probably because fixed combination is convenient for caregivers. Thank you for your attention.
Thank you, everyone, for joining this very interesting session. Very nice talks from all around the world. Lots of very useful information. We have a few questions coming in, but we will also be discussing these with the panelists, and we'll also be asking them a few questions because their talks were very, very interesting. Dr. Patel, I will start by you, and I'm just kind of going with the order of the talks. Dr. Khan could not join us for this part of the discussion, but had a very good talk about the family history and the other genetic causes you do not want to mix up. So thank you, Dr. Khan, for that. Dr. Patel, you did talk about the segmental hypoplasia and the optic nerve hypoplasia. I know that it was a very short time for you to talk about everything, but we really appreciate how well you summarized it. So what do I look for when I see the segmental hypoplasia, or what do I ask for? And if you did mention that, I apologize, I must have missed it. But as a junior, if someone is starting in the pediatric glaucoma world, what do they need to do?
Thank you, Amgad. Firstly, the session was phenomenal. I really enjoyed all the talks. I did not actually touch upon hypoplasia. I was talking more about sort of pseudo-glaucomatous cupping and more of a cup disc. But that's a good point. Hypoplasia is certainly another thing to consider on the spectrum of congenital optic nerve anomalies. You could either have complete hypoplasia, and some of the hypoplastic nerves can be cupped. And some of the typical signs would be a smaller nerve with tortuous thick vessels, with double ring sign where there is a double ring to go outside. These, of course, do need neuroimaging, regardless of it being unilateral or bilateral. They can be associated with other midline anomalies that can have P3 hyperfunction. Segmental hypoplasia on nerve may be associated with maternal diabetes, so that's another thing I would definitely ask. So I hope that answers.
Yeah, no, yes, it does. Thank you. I hope it helps some of our attendees. Dr. Gupta, thank you for the very nice talk about the optic disc and how you shed the light on how important it is to look at the subtle signs and not forget that we are clinicians, not just relying on the machines we have. So thank you very much. The term physiologic cupping, which you used, I do find some of the, I would say, junior physicians or those starting their careers a bit confused about it. So what would you label as a physiologic cup, or how would you normally explain that to your trainees, for example?
Yeah, I think classically the most important thing when you're looking at the optic disc is to look at the rim, because in a lot of these kids, the disc might be very large. And if you carefully look at the rim and you see that the rim is healthy, despite the fact that the disc is large and the cup is large, but the rim is relatively healthy, you're pretty certain. But then again, you have to take the entire clinical picture into account. You have to look at the corneal diameters, you have to look at the axial length, the intraocular pressure. All of these things have to be taken into account in a child, actually. So that is very different from that of an adult. In adult, probably you're just primarily looking at the optic disc, but in a child, you're looking at many other things apart from the optic disc. So yes, if the optic disc is large, it looks like a physiological cupping. Look at the rim before you diagnose that particular child as being glaucomatous. So if the rim is healthy, it's following the isn't rule, more or less, I think you can be safe that it's not a glaucomatous cup.
Perfect. No, I appreciate that. Thank you very much. I think there's a question coming in there. We have a couple of questions for Dr. Zhang. Do we have Dr. Zhang on the discussion part? So I think we have some technical difficulties there. I apologize. While we are still waiting for them, Dr. Gupta, I think there was another question. Oh, we have Dr. Yoshiaki, Dr. Kiyuchi, sorry, I apologize, joining us. So, Dr. Kiyuchi, if you don't mind, we do have a question, and I am asked that by lots of my fellow physicians, where sometimes when we are suggesting starting prostaglandin analogs, I've had several people ask me about the long-term effects of it, whether or not we think it affects the orbital fat or the lid fat, or the long-term effects if we're starting a child who's a few years old on it. What has your experience been in something like that? Or what would your what would your recommendation be?
I think I don't want to use eye drops to children at all, but it is necessary, and but using the prostaglandins, and maybe we can cope with side effect of prostaglandins when compared to the loss of the visual field. So I don't want to use, but I must use.
I agree. Yes, thank you very much. And I have found it, I mean, I do sometimes recommend it to my patients, or most of the time I try to recommend it, especially in the very beginning, but I have not found the punctal occlusion, which is, one of the textbook recommendations, very successful in children. I think it just adds to the ordeal. Is it something you try to have your patients strictly use if you're going to start them on drops, or you just, do you understand my question? That I don't stress on it too much. Is it something you do stress on it because of the side effects?
So just using the eye drops is a very large burden for the patient caregivers. So I don't discuss or recommend them to occlude nasolacrimal gland. So just please use eye drops routinely.
Yes. Okay. Thank you very much, Dr. Kyuchi. And if you do start someone on eye drops, and this is for Dr. Kyuchi or pretty much the whole panel, what is the time frame for which you bring them back to see whether or not you've had an effect started?
Hello?
Hello?
Yes, Dr. Zhang. Welcome back. Thank you.
Mm-hmm.
So, Dr. Zhang, we had a couple of questions coming in for you. I hope you don't mind just sharing your expertise with us. So, one of the questions here in the chat was saying, what degree of Schlemm's canal incision would you suggest in childhood glaucoma?
Okay. I think it's a very good question. Just I mentioned in my presentation, goniotomy have different range, but which one is better remain investigation. I searched the literature showed that 90 degree, 120 degree, 180 degree, 240 degree, or even 360 degree, there are no significant difference so far. For my experience, for primary surgery, I would prefer 360 degree goniotomy, that is GATT. But if for re-operation surgery, such as foreign failure, trabeculectomy, or tube shunt, I just present in my video, you can see, I will perform 120 or 240 degree, which are more convenient. Thank you.
Thank you very much. And another question for you, Dr. Zhang, was I think this was after watching your video, and especially the two last videos about the ones with a tube and the one after a trabeculectomy. The question is saying, why didn't you start with the angle surgery first, and why was the angle surgery decided on after those surgeries?
Well, the mix encounter in China is not that long, only several years. In my place, only 2 years. So so whenever we that is why we have so many patients. You can see foreign the trabeculectomy or tube shunt or even the express. And then we just try go back to use the goniotomy to perform. And then we can find that we successfully to control the IOP so far. I think it is a very good choice. That is why I believe that there are consensus or guidelines to tell us that angle surgery should be the first choice for their tribal glaucoma.
Perfect. Okay, thank you. So, Dr. Patel, if you don't mind, I will go back to you because you mentioned some very, very nice things about some neurological presentations that could be there. And I think I have seen at least a couple of patients with that slight morning glory disc appearance. And I've had, I think, at least one of them who had no knowledge of it and no investigations done before. And would you would usually initiate that workup for the patient, or would you just tell them you have more of a morning glory disc anomaly and less concern for glaucoma? This is more for what would I do next?
No, that's a great question. So morning glory definitely has systemic associations, and I think just saying that it's not glaucoma would not be enough. I would definitely image. So you get an MRI and an MR angiogram as well. There is an association of moya-moya disease with morning glory, and that's really something that shouldn't be missed. Moya-moya is also can develop with time, so a single MRI is not enough. So I would get a vascular neurologist involved and make sure the child has a follow-up.
Okay, thank you very much. Just making sure we didn't have any other questions coming in while we were talking at the moment. So I do have an interesting question. I did ask just a few minutes ago. So if I have a patient that is a suspect and I started them on therapy in terms of medical therapy, eye drop therapy, how soon do you bring the patient back? And this is for all the panelists, if you don't mind sharing your experience. Would you see them in a few weeks? Do you want to wait 2 weeks? Do you want to wait 6 weeks? I know there's no consensus on that, but if you don't mind sharing your experience on it.
I think basically it would depend upon to what extent has the eye drop lowered the intraocular pressure. If the eye drops has lowered the intraocular pressure significantly in a child, it's come down to 10, 12, you can still kind of wait, and you may not require the child to be taken up in the operation theater, and you can probably go on with medical therapy for a long period of time. On the contrary, there are children where the eye drops do not bring the intraocular pressure to the levels that you would want, especially if the optic disc is extremely cupped, in which case you would like to bring the child much earlier. So if the IOP is, let's say, borderline 22, 23, you would like to bring in the child earlier and try to bring down the intraocular pressure. You see, the aim is to be able to cause a reversal of the cupping, which can happen in a child if you can bring down the intraocular pressure significantly lower. So it's very different from that in an adult, where you would not expect or want a reversal of the cupping, but in a child you can possibly have it if you can bring down the intraocular pressure significantly lower. So in which case, if it is a borderline or it's high, it's definitely within 2 or 3 weeks you need to get the child inside and probably do the surgery and bring down the intraocular pressure.
The IOP of the childhood glaucoma fluctuates so tremendously, so it is very difficult to judge the effect of the eye drops effect. So I prefer to check the intraocular pressure every month.
Okay.
So after prescribing the new eye drops to the patients, and child do not want to come to hospital so often, but the patient wants to come.
Yes.
Wants to bring them. Yes.
Yes. No, thank you very much. Thank you very much. We are approaching our last minute. I am checking. I don't think we have any more questions coming in the chat. Again, I want to thank you all for finding the time to join us. I know you all have very different time zones. Thank you very much for making time for us and joining us in this very interesting and what I call a challenging topic. Managing these children is a challenge, and thank you all for all the effort and work you do. Thanks to the attendees, thanks to the organizing committee, and I hope you all enjoyed this session. I'm sure I did, and I learned a whole lot from everyone.